So we'll get ready to get started here. If we can now focus on our patient. At this point, our patient has been anesthetized already, and we'll seat the template and have him close, and you can see how well fitted the surgical index is, as well as seating the surgical template. Starting with a 1.5 millimeter diameter twist drill. So I want to secure the first position. Notice that I come in and out to be sure that I don't burn the bone. Now, to secure the other two anchor pins, at this point, with the tripoding effect of the anchor pins open, we should see that the surgical template is stabilized. We're ready to go ahead and use our soft tissue punch. We'll remove soft tissue, but also create the countersinking that is necessary for the style of implants that we are planning to use today, which is the Nobel Speedy Groovy. And you notice I'm not really pressing hard. I'm just trying to place the drill completely through the surgical template. You need to be sure that all of the drills and components are completely seated, because the system is so accurate that if you fail to completely seat that, you will not be able to seat the implant into the proper position. We determined that the anterior two implants will be 10 millimeters. And you can see on this 2 millimeter diameter twist drill the stop at 10 millimeters. So the drill guide fits into the drill sleeve. And again, very little pressure is used. Now it's important to prepare both stabilization sites simultaneously. Next diameter twist drill is the 2.8. What this does is it progressively enlarges the preparation site, minimizing the trauma and the amount of heat that is generated. Now we go to the 3 millimeter diameter twist drill. Again, drill stop at 10 millimeters. And I'm feeling that there's very little resistance at this point. So that tells me that either the bone is very soft, there's a little more resistance here. I think what we're going to do is stop here at the 3.2 twist drill, because I don't feel resistance in either site when I drill to the final depth. Again, there's very little resistance here. A little more resistance here. But I think that will be sufficient. Here what we have is a 10 millimeter Nobel Speedy Groovy implant on the guided fixture mount. Open real wide. Excellent. And there, again, I'm not using any force. I'm letting the implant do the work on its own, which is a self-tapping implant. And you see at 30 newtons, it stopped as soon as it comes in contact with the top of the surgical template. Again, to prevent the tipping of this surgical template, we don't want to hand tighten this until we get the other implant in. Now that's stopped already, so we're going to increase it to 35. And it's still stopped, and we'll increase it now to 40. Now there is no movement there, so what I'm going to do is I'm going to reverse it. So we'll do it by hand. And and just gently loosen that. The reason why I don't want you to try to force this implant down is because you can strip the hex of the implant if you're not careful. So now that we've removed the implant, we're going to hand this back to Caroline. You can see on the tap the markings for the 7, 10, and 13 depths. That was at 7 millimeters. Now we tap it to 10. What we're doing right now is removing the fixture mounts and getting ready to put the template abutments on. The template abutment, as you see here, is specially designed so that when this screw is tightened into the implant, these wings of the abutment expand to tighten against the surgical template. We're going to try to seat these two template abutments simultaneously. And then just getting a feel for when the resistance occurs right there. Same thing here. Now you can see that both are completely seated. So we will continue with our process as far as the... So we'll start with the start drill. Completely seated. .13 millimeter, we obviously cannot use the drill stop, so if you can see, we're all the way to the very top of the drill. This is the 2.8. And fortunately, as was already mentioned, the patient is very cooperative and is able to open very wide so that we're able to gain easy access to this site. So one of the keys, if you're planning on using this technique, is to measure for the maximum interincisal opening. At least 42 to 45 millimeters. So we're ready to go with our implant. So the 11.5 millimeter speedy implant's going here on the right side. And the torque setting is at 40 newtons. I'm feeling grabbing there. There it stopped. Perfect. Now we'll just go ahead and test the torque resistance. extremely adequate. So now we're ready to remove everything, and we're going to ask Dr. Navikar to come in to assist us. And so at this point in time, we're going to be dealing with the prosthesis. And so we can show you the surgical site. So you can see how all the sites have been nicely prepared. And look at the soft tissue, how well removed it is and how well defined. The anterior abutments are the multi-unit non-engaging. Now, you have to understand that with the angulated abutments, that allows me to connect to the multi-unit abutment in the front. We're going to seat the anterior in first. That's correct. It's going very well. In fact, it's going quite well because usually with the abutment screw fixating the angulated abutment, we oftentimes find it difficult to get that completely seated. And we want to tighten this to 35 newtons, which you see right there. Now we'll go and tighten the angulated abutment screw. This one should be tightened only to 15. Right there. I'm going to turn this back over now to Dr. Navikar, who has just inserted the prosthesis, and you can see the beautiful occlusion that he has set into this. I think we have a winner here. From the standpoint, I'll turn to your left, of the occlusion posteriorly, turn back to your right, and your occlusion anteriorly.
It has 3 cylinders in place. The 4th one is open at the moment. We will put in a temporary abutment in place. Open, please. Open.
Yes, I can hear you. Thank you. That's not what Barrett says.
Is that right?
What we're doing is basically the 3 abutments were already connected into the temporary prosthesis. We have the 4th one, which we have picked up in a little light cure material, and we have blocked out the screw access hole, as you can see, to prevent any material from flowing in and making it inaccessible. We just light cure this into place. We have got all 4 abutments into position now, and what you need to do then is, of course, is remove the bridge, look at the tissue surface, fill in the tissue surface with more acrylic, polish it, and then seat it back into position. The screws are all tightened at 15 newtons a centimeter. As we have picked up the 4th abutment into the bridge, and we need to clear this up and fill this up with acrylic and polish it. As you can see now, the acrylic's been packed into the space that has been created. We're waiting for it to set. We'll polish it and put the bridge back into position. As you can see, what we're doing, we're just trimming the acrylic from the abutment, polishing it. We're now tightening the anterior 2 abutments. These screws will now be torqued in at 15 newtons. We're putting them in at 15 newtons. For any bone-anchored prosthesis, I normally, the old-fashioned way of doing a mutually protected, we have centric stops, and we have the anteriors protecting the molars in protrusion and the canine in lateral function. I think everything seems to be all right. We probably may have to make a couple of adjustments, but I certainly think we can do that later, yeah. Peter's right behind me.
And here you can see our patient, where we're ready to have him smile very large for you. Give us a real big smile, if you would. I think it looks absolutely gorgeous. And it couldn't have been done any better from the prosthetic laboratory standpoint.